Welcome all of you, and I'm very happy to be here to talk to this very variant audience from all over the world. I'm very happy to be here. I'm going to share you the experience, our experience in Sudan in managing spinal tumors. I have started this study a long time ago, maybe from 1995, and still it is going till now, but I'm going to present some of the patients who were being treated by here our colleagues, me and our colleagues here in Sudan. And this presentation is prepared by about 4 of the authors, and I'm the main one. And as a start, we are going to talk about the spinal tumor in general, and after that, we are going to show our experience. So spinal tumors represent one of the most common conditions that frequently seen by the neurosurgeon, and the neurosurgeon sometimes find difficulty in managing and diagnosis of these conditions. So he should have a global view in approaching this problem so as to reach the correct diagnosis and then to put the plan for the management. In the literature, spinal tumors represent about 5 to 10% of all skeletal neoplasm. Primary interspinal tumor comprises only between 10% to 15% of the all central nervous system tumors. They have higher incidence in younger children, and they are associated in many instances with aggressive morbidity that may end with paraplegia. The classification of the spinal tumors, they are classified either into primary spinal tumors that represent the spinal tumors that arise from the spinal cord and its structures. And secondary spinal tumors, this is the second group, are the tumors that come from other areas to the spine. And these are usually malignant tumors. The spinal tumors, the primary spinal tumors, are further subdivided into, according to the location, into intradural, that's the tumors inside the dural sac, and extradural, that means the tumors outside the dura. And the intradural tumors are further subdivided into extramedullary, that the tumors touching the cord from outside and not arising from the cord itself, and intramedullary tumors. So the division of this, or the classification of these tumors, is according to their relation to the spinal structures. The main presentation of the spinal tumors are backache or neck pain according to their location, and neurological dysfunction. And the neurological dysfunction might be motor weakness involving one or more of the limbs, and spasticity according to the site of the tumor, whether it is affecting the lower motor neuron parts or affecting the upper motor neuron. If it affects the upper motor neuron, that means in the cervical or dorsal area to the lower limb, it will cause spasticity in the lower extremities. And sensory disturbances in the form of sensory impairment, and sphincteric disturbances in the advanced cases. The complications are deformities of the limb, the bed sores, deep venous thrombosis, and psychological disorders and other complications. And most of these complications are due to loss of movement, and the patient get bedridden or wheelchair ridden, and this will cause most of these complications. To approach the diagnosis of these conditions, we have to go classically. We have to go through the history of the patient. We have to do clinical assessment or examination, and we have to do some investigations. The main modality of investigations used nowadays is the magnetic resonance imaging, and sometimes we use X-rays, plain X-rays. In the past, we used myelography, conventional myelography, and CT scan and CT myelography. CT scan is now used because it is less invasive, but CT myelography is rarely used nowadays. And CT scan will help to delineate the bony lesions and the extension of the tumor into the bone, rather than to the soft tissue of the cord or roots, because this will not appear easily in the CT scan, but they appear in MRI. So sometimes we might resort to both to know the exact extension of that tumor. The treatment in most instances is surgical intervention in the form of total resection of the tumor, if it is possible, either through anterior or posterior approaches according to the location of the tumor. Partial resection should not be the aim, because in this case, we are going to leave, or in this situation, we are going to leave some of the tumor behind, and that tumor might recur back again. And the second look into the spinal cord or doing another surgery is usually more difficult than the primary one. So we should not aim to partial resection. We should aim at total resection as much as possible. But partial resection, sometimes we resort to it because sometimes we are obliged to do that, because if we do aggressive resection, that might affect the remaining neurological function of the patient. And so in this case, for safety, we are going not to remove the whole tumor if it's affecting the neurological function more than the tumor itself. By the surgery, if it affects that, so we have not to do that as much as possible. Spinal stabilization, we resort to spinal stabilization if the tumor is causing some spinal deformity or spinal, or we are going to end in spinal instability. And so in this case, we should plan to do spinal instrumentation or stabilization at the surgical time. Neurosurgical embolization maybe, this is for the future maybe, and this is used nowadays, but is not well developed as other procedures. And in this case, we are going to deprive the tumor from its blood supply, and that will kill the tumor cell, and the patient will recover after the tumor cells are not living so more. We are also using radiotherapy and chemotherapy for the malignant types, and these are used according to the histopathological report and the effect of different types of chemotherapeutic agents or different radiotherapy procedures on the tumor. Here I'm going to show you some of my cases. The first case is 35-year-old housewife. She presented with neck pain and all extremities heaviness, and that is extending for 3 months. And the examination revealed grade 3 quadriparesis. Here is the MRI. You can see here, this is an upper cervical tumor extending up to C2, and above it there is a small pharynx, and the tumor is expanding the cervical cord from the upper dorsal or D1 vertebra, the level is extending from there to upstairs, up to T or to C2. And that tumor was operated, and histopathology showed pilocytic astrocytoma. This is the operative imaging of this patient. In this patient, we used to do laminotomy, and we don't use here laminectomy because even in a small tumors extending not more than 1 vertebra, I'm using laminotomy. That's I am going to open the laminas laterally and elevate them and to do resection of the tumor and to put them back again. Here is opening through the dura, and the tumor is extending the cord, expanding the cord. And here after resection, the third image here after resection, and this is a specimen sent for histopathology. This is another patient who is 48 years old, worker, and presented with neck pain and all extremities heaviness, beside numbness and spasticity affecting all extremities, and that extend for a duration of 6 months. The examination revealed grade 4 spastic quadriparesis, and the MRI showed, as you can see here, this is a well-developed lesion here, and it is to one side of the cord, as you can see here in the axial MRI is extending through the neural foramen as it is appearing here. So the histopathology showed it was a schwannoma. This is the operative video of the patient. Here you can see this is the cord, and this is the tumor here is two sides of the cord, and although it is extending through the canal, but is expanding the canal, and the tumor has been resected totally by dissection and coagulation and piecemeal removal. Another patient who is 43 years old lady, she presented with inability to walk and heaviness of the lower extremities, besides spasticity, numbness, and urine retention. And the examination revealed grade 0 spastic paraplegia and lower extremities hypoesthesia. The MRI showed this lesion here. You can see it's white. It is clearly that is arising from the dura and is compressing the cord. And so the histopathology showed it was a meningioma, and this is the video of the operation. Here you can see, although it is not so clear, but is here, this is the tumor. The tumor is very calcified very much, and it's like a bone here. That is the cord here, and here I'm separating the cord from the tumor, and or the tumor from the cord, and here is a specimen of the lesion. The patient number 4 is 9 years old female lady and presented with 3 months history of neck pain, all extremities weakness, especially in the left side, and started following fall from an animal. She was unable to walk, but no sphincter disturbances are there. In examination, she was bedridden, and she has grade 4 weakness of all of the right side and grade 3 of the left side. The power is grade 4 there, and here is grade 3. And she has some spasticity and increased reflexes, and sensation were difficult to assess. She was not aware of that. And she has tender cervical spine. The MRI showed this extensive lesion extending from D2 up to C2 and expanding the cord, as you can see here in the axial view. And the histopathology was hemangioblastoma. Also, in this case, I have done laminotomy, and you can see here I'm elevating the spinous processes, and here opening, and then open the dura and resect the tumor from inside the cord. The patient was stabilized after the surgery, also has long recumbency in bed. This is the patient, this is the MRI, post-operative in the patient. It shows some degree of kyphosis. Here is a 17 years young lady. She presented with both lower and upper extremities heaviness. She was a student in the university, and the weakness is more in the right side. And she was conscious on right side, grade 3, and the left side, grade 4. And this is the MRI showing a lesion here as the side of the cord. As you can see here in the axial, it is here globular, and this cord has been pushed to one side. And this is the lady at the theater before. We are checking her gait before the operation. And you can see here the right side is so weak, she can walk with difficulty, and even the left side is also affected more. And this is the operative video. You can see here this is the tumor, and we are dissecting it from the cord. And this is a tumor is coming out. You can see it. We have to go gently to maintain that. Here is totally separated, and I think there is a small root attached to it. We have to coagulate it and cut it. And to proceed, and this is the post-operative MRI of the lady, and the lady got recovered totally and get back to her, went back to her, or go back to her university. This is 65 years, male farmer, presented with lower extremities, weakness, paresthesia, and low back pain and neck pain, and his condition was gradually progressive. He was ill and was only able to walk with difficulty and with support. And he has both lower extremities, grade 3 spastic weakness, and we have operated on him. This is the MRI showed D1 and D2 space occupying lesion here, and this is the lesion here. And after the surgery, the history showed it was schwannoma. This is the operative video. You can see this is the tumor. This is the tumor, and that is at the edge is a small cord. This is a cord here, and to the side, and we are here dissecting the tumor from the cord. You can see here the upper end of the lower end of the tumor, and we are finding a plate here to go through. And this is after getting rid of it. It is very big. It's, you cannot imagine it is big like this. And that is the core behind it is intact. And we have to coagulate and resect some roots or adhesions sometimes that are making attachment of the tumor to the cord. You are washing and then we're getting rid of the tumor. This is a 27 years male cattle keeper presented with low back pain and both lower extremities heaviness and numbness, but no eccentric disturbances that extend for 7 years. Looks well generally, and he has grade 4 lower limb weakness and wasting of both lower extremities with hypoesthesia and at the 10 sensory level. And he has both lower extremities hyperreflexia and hypotonia. This is a big tumor. You can see here it is extending from lower lumbar to the upper lumbar spine, and another one here in the dorsal spine. We have to do resection of both, and histopathology was hemangioblastoma. This is operative images showing that the wound is very extensive. We have done extensive wound in the skin and muscles, and laminectomies was only confined to the size of the tumor. This is the patient in the clinic after few months, and he is very happy about the result. He can walk with a stick and some support. Another patient who is 33 years old male, presented with all extremities with paralysis, numbness, and both urine and stool incontinence, and of shorter duration. He has also some breathing difficulties. He looks ill and dyspneic, but conscious. He has a spastic paralysis grade 0 of lower extremities and grade 2 in the upper extremities. This is the MRI. You can see here a very big tumor here upstairs in the upper cervical spine, and you can see here in the axial view it is extending to the left side mainly. And after the surgery, the histo came as malignant schwannoma. This is the operative we are working here extradurally, and this is part of the tumor. The tumor is so extensive, we have to work for a while to remove it totally, and looks like as if it is composed of many pieces attached together. This is the tumor. It was totally resected. It was so aggressive and adherent to the tissues. Another patient presented with 30 years old lady, presented with neck pain and upper extremities and left lower extremity numbness and weakness for 1 year. She was conscious but looks unwell, and left side was grade 4. It's hypotonic. MRI showed this craniocervical, upper cervical, and extending to the tip of the clivus tumor. And after the resection, the histo came as meningioma, and this is we have to work from one side to resect the tumor. That is a cord, and this is the tumor here. We could resect it totally, and the patient showed recovery after that. This is a tumor. We have to be very cautious because the patient has respiratory problem. I have to go rapid for the sake of time because these cases are too many. It was a difficult operation, but we succeeded to remove the tumor. This is her arm here holding the tumor to resect the last pieces of the tumor. This boy, 6 years, born presented with back deformity and right upper extremity numbness and disturb or impulse gait for duration. He was conscious and looks well, but there was dorsal kyphoscoliosis. And this is his MRI here. And the patient has a syrinx upstate. You can see it here. It is syrinx extending from the dorsal to the cervical spine. And we have done for him syringe subdural shunting and through laminotomy. And he showed initial recovery, but later on he came back again with the weakness and inability to walk. And we have to redo here. We have seen, you can see here, some abnormal tissue. It was not appearing in the initial MRIs. He has been done, and we have found an intramedullary tumor, and the histopathology came as hemangioblastoma. We have operated on these patients for 3 times, but because it was laminotomy, it was easy to reoperate. And anybody who is going to do laminectomies, he will find the second look is very difficult, but in laminotomy it was easy. Here, the patient, we are opening the cord, and this is the tube. We have put a syringe subdural for the syringomyelia. This is the tube. It was there. It was put in the previous operation, and here you can find that is a cord, and this is a tumor. Here we are resecting it. And this is the patient after the operation. You can see him. He is in a good shape and he is walking. I think this is the last patient. It's 42 years male patient presented with both lower extremities, paresthesia and urinary retention, paralysis for lower limbs also for 6 months, and is progressive. He looks generally well, but has grade 1 power in the right lower extremity and 0 in the left side. And sensory level at D7. This is MRI showing here a space occupying lesion here, and you can see it here. And the patient has been operated. You can see it's very big tumor here. This mostly is a schwannoma. Here we are resecting the tumor from the cord in the lumbar area. The aim of this study was to show the experience of the National Center of Neurological Sciences in managing spinal tumors in Sudan, and to give advice to achieve good functional outcome and avoidance of complication. It illustrates the problems and the complication encountered during the management of the patient. The study period extends from January 1995 to December 2090. And the total number of the patient came for management and underwent spinal surgery during that period was 2,533 patients, and total number of the patients found to have spinal tumors were 355 patients. This represents 12.7%. And the age was ranging from 2 years to 82, and the mean was 39.4, and the standard deviation was 17, almost 18. The sex, females represent about 44% of the patient, and the male represent 55. And the duration and the occupation, the female, although they are 44, but because they represent half of the community or more, they represented the majority, housewife were majority, but other occupations like workers, students, farmers, professionals are also encountered. And this is the main presentation. It presented usually with lower extremities weakness in 92% and backache in 78% and sensory impairment in 82%. And synthetic disturbances came in the bottom. The duration of symptom, we found two peaks. In the first year, we found that when from 1 to 6 months is the duration. Most of the patients got afraid from weakness in the limbs and back pain, and so they used to come somewhat earlier. But some patients with very benign tumors not going or not growing so rapidly, they tend to present late. So up to 5 years, you might find some patients who are coming with spinal tumors. And this is the MRI findings. It was mostly the tumors were located in the dorsal area, and followed by the lumbosacral area and then cervical area. Maybe because the dorsal area is the longest in the spinal column or vertebral column. And MRI was done here for 76% of the patient, because some patients from 90s, we are during that time using the myelography and the CT myelography. MRI was not available at that time. And this is the histopathology. You can see here meningioma came as the most common tumor in Sudan, usually in ladies. And then followed by schwannomas and other lesions. The type of operation was laminectomy, because this is ranging for a long time, because initially we were using laminectomy, and later on in the last few years we are using laminotomy. And we have to use some spinal instrumentation in some patients, which is a few number, because here we are dealing mostly with intradural tumor. And the outcome is cure in most of the patient and improvement in the other part of the patients. Some patients remain static, some deteriorated, and this is a mortality. I will show you the figures after a while. And some lost their follow-up. The cause of mortality was mainly pulmonary embolism, which is, and respiratory failure, which is associating the upper cervical tumors. And in the dorsal and the lumbar region, there was no more clear mortality, but in some patients you find infection, meningitis, septicemia, and convulsions also. And this is the complications. You can see that urinary complications are the most common. And the difficulties encountered during the management of these patients was late presentation, because our country was at that time was the largest African and Arab country. And so patients need to go very far distance to find medical advice. And during the earlier period of this study, there was only one center, which was our center, who is going to deal with such cases. And so late presentation, and the patient come with advanced neurological dysfunction, as you can see in the cases, and the tumor were very large in many instances, as you could see in the lesion. The vascular tumors represent somewhat difficulty in management, and they have some higher rate of complications, and also the intramedullary tumors. And also the lack of facilities and difficulties to do instrumentation during that time and stabilization. The protocol of surgical intervention used in these patients was as follows: full planning before surgery, including full imaging, including MRI, CT scan, plain X-rays, and other investigations, and maximal resection of the tumors with special care to normal neurological and vascular structures so as to avoid their injury. And that was achieved by using the following: proper localization of the site of the tumor within the spinal canal, utilizing the radiological and clinical information available, and the surgical mode is planned to involve one level above and one level below the tumor so as not to work in a normal cord and to work only and to see the ends of the tumors. Laminotomy is used instead of laminectomy in the cases in the last years, and that was found very beneficial and helps the patient to in rapidly healing of his wounds and recovery. And if he needs another session, it will be easier. And that was possible by using a small caissons or laminotome. Surgical microscope is very essential to be used in such cases so as to see the tiny structures and the tiny anatomical structures. Ultrasonic aspirator is also helpful, and microsurgical instruments. Identification of the line of the cleavage between the tumor and the normal spinal tissue makes the use of arachnoid layer to see this or to make use of this line of cleavage so as not to injure the cord. Minimizing the use of bipolar and cauterization to the bleeding points only with the use of, this is going to be easier under microscope, and use of water irrigation to minimize the heat effect, and covering of the normal neural tissue with cottonoids with irrigation from time to time so as not to be injured mechanically or accidentally or by dryness. And the use of spinal neuro monitoring, which is not available till now in Sudan. This will help to protect the normal neural tissues, and especially in intramedullary tumors. In case of operating intramedullary tumors, one should be able to identify the line of cleavage between the normal tissue and the tumor. To proceed, the resection in that line. Such dissection is easier in certain tumors like ependymoma, while it is very difficult in other tumors such as astrocytomas. And so in that cases, we are expecting to have some problem as regarding the neurological function in this patient. So as in such case, we have not to be very tough with the normal spinal tissues, and to we might oblige to be or to make some or to leave some of the tumor so as not to damage the normal tissue or its vessels also, that will end in neurological dysfunction. Minimizing the use of Sergicel and gel foam so as not to be as a mass after the operation, and watertight closure of the dura. This will make the life easy, because any CSF leak after the operation, this will be a headache and will help to develop infection. In case of laminotomy, fixation of the spine can be done with using either microblades or screws or non-absorbable sutures. To conclude, spinal tumors are in most instances or in most conditions are curable, that require attention in diagnosis and treatment, and the presentation of the tumors is unique, with some difficulty might be faced in pediatric group who contribute large number of the patient. The diagnosis is made easily with the aid of the MRI and should be resorted to as in any case of suspicion. And benign tumors like meningiomas and schwannomas constitute the bulk of the cases. And so every effort must be done to achieve total resection of these tumors. Even though in malignant intramedullary tumors, total meticulous resection can be achieved, and the treatment is almost, in most instances, is surgical. And the use of microsurgical techniques might help to improve the result of the treatment, and early detection of the tumors will help to improve the result of the treatment and to reduce the complication. Thank you very much for your attention and your patience to hear me. Thank you.
Thank you very much, Doctor, for this enlightening presentation. If it's all right with you, I'd like to ask a question.
Yes, you're welcome.
While I was listening to your presentation, I was asking myself, are there spinal tumors which are more common in female than in male?
Yes, of course. Usually the benign tumors like meningiomas are so common in the females. And this, as you can see from our study, is the bulk of the tumors, is that the highest number of the patients are of meningioma type, and that tend to affect the patients, the female patients, because even in the meningiomas of the brain, they are usually females. The malignant tend to affect the young children. And also the male population that are affected by the malignant, but also by the benign like schwannomas and neurofibromas.
Thank you very much. I'd like to thank again everyone involving in this Congress, and I wish you a good day or a good evening, depending where you're listening from. Thank you again, Doctor.
Thank you. Thank you very much.
Thank you very much, Doctor. It was a really interesting presentation. And we're so glad that you have been here for today. We really appreciate that. So thank you very much once again.
Okay, thank you.
No, thank you.